Parathyroid glands and physiology of bone. Introduction. Human beings have 4 parathyroid glands, which are situated on the posterior surface of upper and lower poles of thyroid gland, Fig 68.1. Parathyroid glands are very small in size, measuring about 6 mm long, 3 mm wide and 2 mm thick, with dark brown color. Histology. Each parathyroid gland is made up of chief cells and oxyphil cells. Chief cells secrete parathormone. Oxyphil cells are the degenerated chief cells and their function is known. However, these cells may secrete parathormone during pathological condition called parathyroid adenoma. The number of oxyphil cells increases after puberty. Parathormone. Parathormone secreted by parathyroid gland is essential for the maintenance of blood calcium level within a very narrow critical level. Maintenance of blood calcium level is necessary because calcium is an important inorganic ion for many physiological functions, see below. Source of secretion. Parathormone, Pth, is secreted by the chief cells of the parathyroid glands. Chemistry. Parathormone is protein in nature, having 84 amino acids. Its molecular weight is 9,500. Half-life and plasma level. Parathormone has a half-life of 10 minutes. Normal plasma level of Pth is about 1.5 to 5.5 ng/dl. Synthesis. Parathormone is synthesized from the precursor called pre-pro-Pth containing 115 amino acids. First, the pre-pro-Pth enters the endoplasmic reticulum of chief cells of parathyroid glands. There it is converted into a prohormone called pro-Pth, which contains 96 amino acids. Pro-Pth enters the Golgi apparatus, where it is converted into Pth. Metabolism. 60 to 70% of Pth is degraded by Kupffer cells of liver, by means of proteolysis. Degradation of about 20% to 30% Pth occurs in kidneys and to a lesser extent in other organs. Actions of parathormone. Pth plays an important role in maintaining blood calcium level. It also controls blood phosphate level. Actions of parathormone on blood calcium level. Primary action of Pth is to maintain the blood calcium level within the critical range of 9 to 11 mg/dl. The blood calcium level has to be maintained critically because it is very important for many of the activities in the body. Pth maintains blood calcium level by acting on bones, kidney, gastrointestinal tract, on bone. Parathormone enhances the resorption of calcium from the bones, osteoclastic activity, by acting on osteoblasts and osteoclasts of the bone. Resorption of calcium from bones occurs in 2 phases, rapid phase, slow phase. Rapid phase. Rapid phase occurs within minutes after the release of Pth from parathyroid glands. Immediately after reaching the bone, Pth gets attached with the receptors on the cell membrane of osteoblasts and osteocytes. The hormone receptor complex increases the permeability of membranes of these cells for calcium ions. It accelerates the calcium pump mechanism, so that calcium ions move out of these bone cells and enter the blood at a faster rate. Slow phase. Slow phase of calcium resorption from bone is due to the activation of osteoclasts by Pth. When osteoclasts are activated, some substances such as proteolytic enzymes, citric acid and lactic acid are released from lysosomes of these cells. All these substances digest or dissolve the organic matrix of the bone, releasing the calcium ions. The calcium ions slowly enter the blood. Pth increases calcium resorption from bone by stimulating the proliferation of osteoclasts also. On kidney. Pth increases the reabsorption of calcium from the renal tubules along with magnesium ions and hydrogen ions. It increases calcium reabsorption mainly from distal convoluted tubule and proximal part of collecting duct. Pth also increases the formation of 1,25-dihydroxycholecalciferol, activated form of vitamin D, from 25-hydroxycholecalciferol in kidneys, see below. On gastrointestinal tract. PTH increases the absorption of calcium ions from the GI tract indirectly. It increases the formation of 1,25-dihydroxycholecalciferol in the kidneys. This vitamin, in turn, increases the absorption of calcium from GI tract. Thus, the activated vitamin D is very essential for the absorption of calcium from the GI tract. And PTH is essential for the formation of activated vitamin D. Role of PTH in the activation of vitamin D. Vitamin D is very essential for calcium absorption from the GI tract. But vitamin D itself is not an active substance. Instead, vitamin D has to be converted into 1,25-dihydroxycholecalciferol in the liver and kidney in the presence of PTH. The 1,25-dihydroxycholecalciferol is the active product. Activation of vitamin D. There are various forms of vitamin D. But, the most important one is vitamin D3. It is also known as cholecalciferol. Vitamin D3 is synthesized in the skin from 7-dehydrocholesterol, by the action of ultraviolet rays from the sunlight. It is also obtained from dietary sources. The activation of vitamin D3 occurs in two steps, Fig 68.2. First step. Cholecalciferol, vitamin D3, is converted into 25-hydroxycholecalciferol in the liver. This process is limited and is inhibited by 25-hydroxycholecalciferol itself by feedback mechanism. This inhibition is essential for two reasons: regulation of the amount of active vitamin D, storage of vitamin D for months together. If vitamin D3 is converted into 25-hydroxycholecalciferol, it remains in the body only for 2 to 5 days. But vitamin D3 is stored in liver for several months. Second step. 25-hydroxycholecalciferol is converted into 1,25-dihydroxycholecalciferol, calcitriol, in kidney. It is the active form of vitamin D3. This step needs the presence of PTH. Role of calcium ion in regulating 1,25-dihydroxycholecalciferol. When blood calcium level increases, it inhibits the formation of 1,25-dihydroxycholecalciferol. The mechanism involved in the inhibition of the formation of 1,25-dihydroxycholecalciferol is as follows: increase in calcium ion concentration directly suppresses the conversion of 25-hydroxycholecalciferol into 1,25-dihydroxycholecalciferol. This effect is very mild. Increase in calcium ion concentration decreases the PTH secretion, which in turn suppresses the conversion of 25-hydroxycholecalciferol into 1,25-dihydroxycholecalciferol. This regulates the calcium ion concentration of plasma itself indirectly, i.e. when the PTH synthesis is inhibited, the conversion of 25-hydroxycholecalciferol into 1,25-hydroxycholecalciferol is also inhibited. Lack of 1,25-dihydroxycholecalciferol decreases the absorption of calcium ions from the intestine, from the bones and from the renal tubules as well. This makes the calcium level in the plasma to fall back to normal. Actions of 1,25-dihydroxycholecalciferol. It increases the absorption of calcium from the intestine, by increasing the formation of calcium-binding proteins in the intestinal epithelial cells. These proteins act as carrier proteins for facilitated diffusion, by which the calcium ions are transported. The proteins remain in the cells for several weeks after 1,25-dihydroxycholecalciferol has been removed from the body, thus causing a prolonged effect on calcium absorption. It increases the synthesis of calcium-induced ATPase in the intestinal epithelium. It increases the synthesis of alkaline phosphatase in the intestinal epithelium. It increases the absorption of phosphate from intestine along with calcium. Actions of parathormone on blood phosphate level. PTH decreases blood level of phosphate by increasing its urinary excretion. It also acts on bone and GI tract. On bone. Along with calcium resorption, PTH also increases phosphate absorption from the bones. On kidney. Phosphaturic action. It is the effect of PTH by which phosphate is excreted through urine. PTH increases phosphate excretion by inhibiting reabsorption of phosphate from renal tubules. It acts mainly on proximal convoluted tubule. On gastrointestinal tract. Parathormone increases the absorption of phosphate from GI tract through calcitriol. Sequence of events. PTH converts 25-hydroxycholecalciferol into 1,25-dihydroxycholecalciferol, calcitriol, active form of vitamin D3, in kidney. Calcitriol increases the synthesis of calcium-induced ATPase in the intestinal epithelium. ATPase increases the synthesis of alkaline phosphatase. Alkaline phosphatase increases the absorption of phosphate from intestine along with calcium. Mode of action of parathermone. Parathermone receptors. Parathermone receptors, PTH receptors, are of three types, PTHR1, PTHR2 and PTHR3, which are G-protein coupled receptors. PTHR1 is physiologically more important than the other two types. PTHR1 mediates the actions of PTH and PTH-related protein, see below. Role of PTHR2 and PTHR3 is not known clearly. On the target cells, PTH binds with PTHR1 which is coupled to G-protein and forms hormone receptor complex. Hormone receptor complex causes formation of CAMP, which acts as a second messenger for the hormone. Regulation of parathermone secretion. Blood level of calcium is the main factor regulating the secretion of PTH. Blood phosphate level also regulates PTH secretion. Blood level of calcium. Parathermone secretion is inversely proportional to blood calcium level. Increase in blood calcium level decreases PTH secretion. Conditions when PTH secretion decreases are, excess quantities of calcium in the diet. Increased vitamin D in the diet. Increased resorption of calcium from the bones, caused by some other factors such as bone diseases. On the other hand, decrease in calcium ion concentration of blood increases PTH secretion, as in the case of rickets, pregnancy, and in lactation. Blood level of phosphate. PTH secretion is directly proportional to blood phosphate level. Whenever the blood level of phosphate increases, it combines with ionized calcium to form calcium hydrogen phosphate. This decreases ionized calcium level in blood, which stimulates PTH secretion. Applied physiology, disorders of parathyroid glands. Disorders of parathyroid glands are of two types, hypoparathyroidism. Hyperparathyroidism. Hypoparathyroidism, hypocalcemia. Hyposecretion of PTH is called hypoparathyroidism. It leads to hypocalcemia, decrease in blood calcium level. Causes for hypoparathyroidism: surgical removal of parathyroid glands. Parathyroidectomy. Removal of parathyroid glands during surgical removal of thyroid gland, thyroidectomy. Autoimmune disease. Deficiency of receptors for PTH in the target cells. In this, the PTH secretion is normal or increased, but the hormone cannot act on the target cells. This condition is called pseudo-hypoparathyroidism. Hypocalcemia and tetany. Hypoparathyroidism leads to hypocalcemia, by decreasing the resorption of calcium from bones. Hypocalcemia causes neuromuscular hyperexcitability, resulting in hypocalcemic tetany. Normally, tetany occurs when plasma calcium level falls below 6 mg/dl from its normal value of 9.4 mg/dl. Hypocalcemic tetany. Tetany is an abnormal condition characterized by violent and painful muscular spasm. Spasm equals involuntary muscular contraction, particularly in feet and hand. It is because of hyperexcitability of nerves and skeletal muscles due to calcium deficiency. Signs and symptoms of hypocalcemic tetany: hyperreflexia and convulsions. Increase in neural excitability results in hyperreflexia, overactive reflex actions, and convulsive muscular contractions. Carpopedal spasm. Carpopedal spasm is the spasm in hand and feet that occurs in hypocalcemic tetany. During spasm, the hand shows a peculiar attitude, Fig 68.3. Attitude of hand in carpopedal spasm includes, flexion at wrist joint, flexion at metacarpophalangeal joints, extension at interphalangeal joints, adduction of thumb. Laryngeal Strider. Strider means noisy breathing. Laryngeal Strider means a loud crowing sound during inspiration, which occurs mainly due to laryngospasm, involuntary contraction of laryngeal muscles. Laryngeal Strider is a common dangerous feature of hypocalcemic tetany. Cardiovascular changes. Dilatation of the heart. Prolonged duration of ST segment and QT interval in ECG. Arrhythmias, irregular heartbeat. Hypotension. Heart failure. Other features. Decreased permeability of the cell membrane. Dry skin with brittle nails. Hair loss. Grand mal, petit mal, or other seizures, Chapter 161. Signs of mental retardation in children or dementia in adults, Chapter 162. When the calcium level falls below 4 mg/dl, it becomes fatal. During such severe hypocalcemic conditions, tetany occurs so quickly that a person develops spasm of different groups of muscles in the body. Worst affected are the laryngeal and bronchial muscles, which develop respiratory arrest, resulting in death. Latent tetany. Latent tetany, also known as subclinical tetany, is the neuromuscular hyperexcitability due to hypocalcemia that develops before the onset of tetany. It is characterized by general weakness and cramps in feet and hand. Hyperexcitability in these patients is detected by some signs, which do not appear in normal persons. Trousseau sign. Trousseau sign is the spasm of the hand that is developed after 3 minutes of arresting the blood flow to lower arm and hand. The blood flow to lower arm and hand is arrested by inflating the blood pressure cuff 20 mm Hg above the patient's systolic pressure. Kvostec sign. Kvostec sign is the twitch of the facial muscles, caused by a gentle tap over the facial nerve in front of the ear. It is due to the hyperirritability of facial nerve. Herb sign. Hyperexcitability of the skeletal muscles even to a mild electrical stimulus is called herb sign. It is also called herb Westphal sign. Hyperparathyroidism, hypercalcemia. Hypersecretion of PTH is called hyperparathyroidism. It results in hypercalcemia. Hyperparathyroidism is of 3 types: primary hyperparathyroidism. Primary hyperparathyroidism is due to the development of tumor in one or more parathyroid glands. Sometimes, tumor may develop in all the 4 glands. Secondary hyperparathyroidism. Secondary hyperparathyroidism is due to the physiological compensatory hypertrophy of parathyroid glands, in response to hypocalcemia, which occurs due to other pathological conditions such as chronic renal failure, vitamin D deficiency, rickets. Tertiary hyperparathyroidism. Tertiary hyperparathyroidism is due to hyperplasia, abnormal increase in the number of cells of all the parathyroid glands that develops due to chronic secondary hyperparathyroidism. Hypercalcemia. Hypercalcemia is the increase in plasma calcium level. It occurs in hyperparathyroidism because of increased resorption of calcium from bones. Signs and symptoms of hypercalcemia. Depression of the nervous system. Sluggishness of reflex activities. Reduced ST segment and QT interval in ECG. Lack of appetite. Constipation. Depressive effects of hypercalcemia are noticed when the blood calcium level increases to 12 mg/dl. The condition becomes severe with 15 mg/dl, and it becomes lethal when blood calcium level reaches 17 mg/dl. Other effects of hypercalcemia: development of bone diseases such as osteitis, fibrosis cystic, development of parathyroid poisoning. It is the condition characterized by severe manifestations that occur when blood calcium level rises above 15 mg/dl. In hyperparathyroidism, the concentration of both calcium and phosphate increases, leading to formation of calcium phosphate crystals. Concentration of phosphate also increases because kidney cannot excrete the excess amount of phosphate resorbed from the bone. Deposition of calcium phosphate crystals in renal tubules, thyroid gland, alveoli of lungs, gastric mucosa, and in the wall of the arteries, resulting in dysfunction of these organs. Renal stones are formed when it is deposited in kidney. Parathyroid function tests. Measurement of blood calcium level. Kvostec sign and Trousseau sign for hypoparathyroidism. Calcitonin. Source of secretion. Calcitonin is secreted by the parafollicular cells or clear cells, C cells, situated amongst the follicles in thyroid gland. In lower animals, the parafollicular cells are derived from ultimabranchial glands, which develop from fifth pharyngeal pouches. In human being, the ultimabranchial glands and fifth pharyngeal pouches are rudimentary, and their cells are incorporated with fourth pharyngeal pouches and distributed amongst the follicles of thyroid gland. Recently, calcitonin is found in brain, prostate, and bronchial cells of lungs. However, the physiological role of calcitonin from non-thyroid tissues is not known. Chemistry and synthesis. Calcitonin is a polypeptide chain with 32 amino acids. Its molecular weight is about 3,400. It is synthesized from procalcitonin. Plasma level and half-life. Plasma level of calcitonin is 1 to 2 ng/dl. It has a half-life of 5 to 10 minutes. Metabolism. Calcitonin is degraded and excreted by liver and kidney. Actions of calcitonin. On blood calcium level. Calcitonin plays an important role in controlling the blood calcium level. It decreases the blood calcium level and thereby counteracts parathormone. Calcitonin reduces the blood calcium level by acting on bones, kidneys and intestine. On bones. Calcitonin stimulates osteoblastic activity and facilitates the deposition of calcium on bones. At the same time, it suppresses the activity of osteoclasts and inhibits the resorption of calcium from bones. It inhibits even the development of new osteoclasts in bones. On kidney. Calcitonin increases excretion of calcium through urine, by inhibiting the reabsorption from the renal tubules. On intestine. Calcitonin prevents the absorption of calcium from intestine into the blood. On blood phosphate level. With respect to calcium, calcitonin is an antagonist to PTH. But it has similar actions of PTH, with respect to phosphate. It decreases the blood level of phosphate by acting on bones and kidneys. On bones. Calcitonin inhibits the resorption of phosphate from bone and stimulates the deposition of phosphate on bones. On kidney. Calcitonin increases the excretion of phosphate through urine, by inhibiting the reabsorption from renal tubules. Regulation of calcitonin secretion. High calcium content in plasma stimulates the calcitonin secretion through a calcium receptor in parafollicular cells. Gastrin also is known to stimulate the release of calcitonin. Calcium metabolism. Importance of calcium. Calcium is very essential for many activities in the body, such as bone and teeth formation, neuronal activity, skeletal muscle activity, cardiac activity, smooth muscle activity, secretory activity of the glands, cell division and growth, coagulation of blood. Normal value. In a normal young healthy adult, there is about 1,100 g of calcium in the body. It forms about 1.5% of total body weight. 99% of calcium is present in the bones and teeth, and the rest is present in the plasma. Normal blood calcium level ranges between 9 and 11 mg/dl. Types of calcium. Calcium in plasma. Calcium is present in three forms in plasma: ionized or diffusible calcium, found freely in plasma and forms about 50% of plasma calcium. It is essential for vital functions such as neuronal activity, muscle contraction, cardiac activity, secretions in the glands, blood coagulation, etc. Non-ionized or non-diffusible calcium, present in non-ionic forms such as calcium bicarbonate. It is about 8% to 10% of plasma calcium. Calcium bound to albumin, forms about 40% to 42% of plasma calcium. Calcium in bones. Calcium is constantly removed from bone and deposited in bone. Bone calcium is present in two forms: rapidly exchangeable calcium or exchangeable calcium, available in small quantity in bone and helps to maintain the plasma calcium level. Slowly exchangeable calcium or stable calcium, available in large quantity in bones and helps in bone remodeling. Process of calcium metabolism is explained schematically in Fig 68.4. Source of calcium. Dietary source. Calcium is available in several foodstuffs. Percentage of calcium in different food substances: whole milk equals 10%. Low-fat milk equals 18%. Cheese equals 27%. Other dairy products equals 17%. Vegetables equals 7%. Other substances such as meat, egg, grains, sugar, coffee, tea, chocolate, etc. equals 21%. From bones. Besides dietary calcium, blood also gets calcium from bone by resorption. Daily requirements of calcium: 1 to 3 years equals 500 milligrams. 4 to 8 years equals 800 milligrams. 9 to 18 years equals 1,300 milligrams. 19 to 50 years equals 1,000 milligrams. 51 years and above equals 1,200 milligrams. Pregnant ladies and lactating mothers equals 1,300 milligrams. Absorption and excretion of calcium. Calcium taken through dietary sources is absorbed from GI tract into blood and distributed to various parts of the body. Depending upon the blood level, the calcium is either deposited in the bone or removed from the bone, resorption. Calcium is excreted from the body through urine and feces. Absorption from gastrointestinal tract. Calcium is absorbed from duodenum by carrier-mediated active transport and from the rest of the small intestine, by facilitated diffusion. Vitamin D is essential for the absorption of calcium from GI tract. Excretion. While passing through the kidney, large quantity of calcium is filtered in the glomerulus. From the filtrate, 98% to 99% of calcium is reabsorbed from renal tubules into the blood. Only a small quantity is excreted through urine. Most of the filtered calcium is reabsorbed in the distal convoluted tubules and proximal part of collecting duct. In distal convoluted tubule, parathermone increases the reabsorption. In collecting duct, vitamin D increases the reabsorption and calcitonin decreases reabsorption. About 1,000 milligrams of calcium is excreted daily. Out of this, 900 milligrams is excreted through feces and 100 milligrams through urine. Regulation of blood calcium level. Blood calcium level is regulated mainly by three hormones, Fig 68.5 and 68.6. Parathormone. 1,25-dihydroxycholecalciferol, calcitriol. Calcitonin. Parathormone. Parathormone is a protein hormone secreted by parathyroid gland and its main function is to increase the blood calcium level by mobilizing calcium from bone, resorption, see above for details. 1,25-dihydroxycholecalciferol, calcitriol. Calcitriol is a steroid hormone synthesized in kidney. It is the activated form of vitamin D. Its main action is to increase the blood calcium level by increasing the calcium absorption from the small intestine, see above for details. Calcitonin. Calcitonin secreted by parafollicular cells of thyroid gland. Thyroid gland is a calcium-lowering hormone. It reduces the blood calcium level mainly by decreasing bone resorption, see above for details. Effects of other hormones. In addition to the above-mentioned three hormones, growth hormone and glucocorticoids also influence the calcium level. Growth hormone. Growth hormone increases the blood calcium level by increasing the intestinal calcium absorption. It is also suggested that it increases the urinary excretion of calcium. However, this action is only transient. Glucocorticoids. Glucocorticoids, cortisol, decrease blood calcium by inhibiting intestinal absorption and increasing the renal excretion of calcium. Phosphate metabolism. Phosphorus, P, is an essential mineral that is required by every cell in the body for normal function. Phosphorus is present in many food substances, such as peas, dried beans, nuts, milk, cheese, and butter. Inorganic phosphorus, Pi, is in the form of the phosphate, PO4. The majority of the phosphorus in the body is found as phosphate. Phosphorus is also the body's source of phosphate. In body, phosphate is the most abundant intracellular anion. Importance of phosphate. Phosphate is an important component of many organic substances such as ATP, DNA, RNA and many intermediates of metabolic pathways. Along with calcium, it forms an important constituent of bone and teeth. It forms a buffer in the maintenance of acid-base balance. Normal value. Total amount of phosphate in the body is 500 to 800 g. Though it is present in every cell of the body, 85% to 90% of body's phosphate is found in the bones and teeth. Normal plasma level of phosphate is 4 mg/dl. Regulation of phosphate level. Phosphorus is taken through dietary sources. It is absorbed from GI tract into blood. It is also resorbed from bone. From blood it is distributed to various parts of the body. While passing through the kidney, large quantity of phosphate is excreted through urine. Blood phosphate level is regulated mainly by three hormones: Parathormone, Calcitonin, 1,25-dihydroxycholecalciferol, calcitriol. Parathormone. Parathormone stimulates resorption of phosphate from bone and increases its urinary excretion. It also increases the absorption of phosphate from gastrointestinal tract through calcitriol. The overall action of parathormone decreases the plasma level of phosphate. Calcitonin. Calcitonin also decreases the plasma level of phosphate by inhibiting bone resorption and stimulating the urinary excretion. 1,25-dihydroxycholecalciferol, calcitriol. Calcitriol hormone increases absorption of phosphate from small intestine, Fig 68.7. Effects of other hormones. In addition to the above-mentioned three hormones, growth hormone and glucocorticoids also influence the phosphate level. Growth hormone. Growth hormone increases the blood phosphate level by increasing the intestinal phosphate absorption. Glucocorticoids. Glucocorticoids, cortisol, decreases blood phosphate by inhibiting intestinal absorption and increasing the renal excretion of phosphate.